All of the following regarding lichen planus are true except does not involve mucous membrane. So it involves the mucous membrane also. What is true is associated with hepatitis C, topical steroid are the mainstay of therapy and spontaneous remission in 6 months to 2 years. Pityriasis rosea, true is it is self-limiting. Annular herald patch is seen in pityriasis rosea. A patient of hypertension of ACE inhibitor developed rosea skin eruption. True statement regarding this situation is drug may be the cause and discontinuation may improve the skin condition. Which viral association is found in pityriasis rosacea? It is HHV7. And which of the following statement is true regarding pityriasis rubra pilaris? Isolated patches of normal skin are found and cephalocaudal distribution is there. Keratoderma is a feature of pityriasis rubra pilaris. Koebner's phenomenon is characteristic of psoriasis. Koebner phenomena is seen in following except scleromyxedema. So Koebner's phenomenon is seen in erythema, molluscum contagiosum and Darner's disease. It is not seen in scleromyxedema. In which of the following Koebner phenomena is not seen? It is not seen in lichen simplex chromius. It is seen in lichen planus, lichen sclerosis and erythema multiforme. Koebner's phenomenon is seen in lichen planus, warts, psoriasis and vitiligo. It is not seen in Behcet syndrome. Koebner phenomenon is present in all except none of these. So it is present in psoriasis, lichen planus and warts. Koebner phenomenon present in which of the following? It is present in plain warts. It is not present in pemphigus, lupus vulgaris or lichen simplex chronicus. Isomorphic response can be a feature of the following except tinea. So isomorphic response can be a feature of warts, psoriasis and molluscum contagiosum. Pseudo-isomorphic phenomenon is seen in plain warts. Pseudo-Koebner phenomenon is seen in warts and molluscum contagiosum. Now vesiculobullous, that is blistering disorders. A patient is presenting with non-pruritic painless erythema surrounded by vesicles with erythematous halo on face and hand. There is a history of drug intake for fever 2 weeks back. The patient is suffering from erythema multiforme. A 28-year-old patient has multiple grouped papillovesicular lesions on both elbows, knees, buttocks, and upper back associated with severe itching. The most likely diagnosis is dermatitis herpetiformis. A 30-year-old male had severely itchy papillovesicular lesions on extremities, knees, elbows, and buttocks for 1 year. Direct immunofluorescence staining of the lesion showed IgA deposition at dermo-epidermal junction. The most probable diagnosis is dermatitis herpetiformis. Extremely pruritic excoriation and papules on buttocks with autoantibodies against epidermal transglutaminase and IgA deposition in dermis on immunohistological examination of normal perilesional skin. The diagnosis is dermatitis herpetiformis. A 30-year-old male had severely itchy papillovesicular lesions on extremities, knees, elbows, and buttocks for 1 year. Direct immunofluorescence staining of the lesion showed IgA deposition at dermo-epidermal junction. The most probable diagnosis is dermatitis herpetiformis. A 40-year male presenting with painful flaccid vesicle on face and oral mucosa with asymmetric distribution. Immunofluorescence shows intracellular IgG deposition in epidermis. The diagnosis is pemphigus vulgaris. A 23 years old lady present with vesicular lesion in the buccal mucosa and crusted lesion on the skin. The possible diagnosis is pemphigus vulgaris. A middle-aged female has flaccid bulla in the skin and oral erosion. Histopathology shows intraepidermal acantholytic blister. The most likely diagnosis is pemphigus vulgaris. A female present with persistent painful oral lesion with acantholytic cells, most likely diagnosis is pemphigus vulgaris. A 50-year-old male known case of myasthenia with erythema increased shallow erosions with few blisters and scales. Oral mucosa is not involved. Immunopathology demonstrates IgG deposition on keratinocytes and autoantibodies against DSG1. The diagnosis is pemphigus foliaceus. A 24 years old female has flaccid bulla in the skin and oral erosions. Histopathology shows intraepidermal acantholytic blister. The most likely diagnosis is pemphigus vulgaris. 25 years old female has palatal ulcer and skin blister. Most likely diagnosis is pemphigus vulgaris. A 85-year-old woman with Nikolsky sign negative, blisters on thigh and trunk, lesions come on and off. What is the cause? Pemphigoid. A 56-year-old male Lalu presents with painful bullous lesion in lower extremity. The most likely diagnosis is bullous pemphigoid. A 40-year-old male had multiple blisters over the trunk and extremities. Direct immunofluorescence study showed linear IgG deposit along the basement membrane. Which of the following is the most likely diagnosis? Bullous pemphigoid. A patient with bullous eruption on lower limb and trunk, biopsy showed epidermal bulla. The correct diagnosis is impetigo. A 45-year-old male has multiple grouped vesicular lesion present on the T10 segment dermatome associated with pain. The most likely diagnosis is herpes zoster. Most common pemphigus is pemphigus vulgaris. In pemphigus vulgaris, antibodies are present against intracellular substance. Acantholysis is characteristic of pemphigus vulgaris. A 50-year-old man has a 2-year history of facial bulla and oral ulcers. Microscopic smear from skin lesion is most likely to disclose Zank cell and acantholytic cells. Loss of intercellular cohesion between keratinocyte is called as acantholysis. Acantholytic cells are epidermal cells and keratinocytes. Zank cell is keratinocyte. Acantholytic cells in pemphigus is cell with hyperchromatic nuclei and perinuclear halo. Flaccid bulla lesion with oral mucosal lesion. The finding in immunofluorescence is fishnet IgG in epidermis. All are associated with pemphigus except the atrophic gastritis. So, thymoma, CLL, myasthenia gravis, and non-Hodgkin lymphoma is associated with pemphigus. True about pemphigus vulgaris, it is an autoimmune disease. Zank smear shows acantholytic cell. Antibody are formed against the desmogleins and blister on skin and mucosa. Spontaneous remission is most frequent with herpes gestationis. Drug-induced pemphigus is most commonly caused by penicillamine. Subepidermal bulla on trunk and flexural surface with linear C3 IgG basement membrane deposit are feature of bullous pemphigoid. Mucosa is never involved in which of the following disorder? Dermatitis herpetiformis. One of the following is the treatment of choice for dermatitis herpetiformis. Dapsone. Gluten-free diet is beneficial in dermatitis herpetiformis. All are true about linear IgA disease except that are candidates for gluten-free diet is not true. What is true is it is a subepidermal involvement, severe itching, granular deposition of IgA, and it is a variant of dermatitis herpetiformis. All causes erythema multiforme except HPV. So erythema multiforme is caused by HSV, drugs, or idiopathic. Erythema multiforme is most often related to herpes simplex infection. Most common cause of erythema multiforme is herpes simplex. Target or iris lesion is seen in erythema multiforme. Regarding erythema multiforme, all are true except that there will be no vesicle, that is false. What is true is target lesion are seen, involves face and neck region, and sign of internal malignancy. A 60-year-old patient presented with severe bullous lesion for the last 3 days, each bulla surrounded by an erythematous halo. There were multiple target lesion. Patient also had oral lesion. The most likely diagnosis is Steven-Johnson syndrome. All are true about erythema multiforme except mucous membrane is usually involved. So what is true is it is due to herpes simplex, due to sulfonamide, and lesion are symmetrical. Features of epidermolysis bullosa is ad- increased adhesion fibrils. In an 8-day-old child with no history of consanguinity in the parent, the mother reports blister and bleeding off of the skin at the site of handling and pressure. There was a similar history in the previous child which proved to be fatal. The diagnosis is congenital epidermolysis bullosa. Genetic predisposition is seen in which disease? In epidermolysis bullosa. Etiology of epidermolysis bullosa is genetic. In congenital dystrophic variety of epidermolysis bullosa, mutation is seen in the gene coding for collagen type 7. Which of the following shows granular deposition of IgA in dermal papilla, dermatitis herpetiformis? Skin disease not showing DIF, direct immunofluorescence, is Darier's disease and Haley-Haley disease. So in cicatricial pemphigoid dermatitis herpetiformis and in pemphigus, it shows direct immunofluorescence. Direct immunofluorescence is positive in pemphigus. Intraepidermal intracellular IgG deposition is seen in pemphigus. A patient presented with multiple vesicles over the body with fishnet-like IgG deposition in the epidermis, most likely diagnosis is pemphigus vulgaris. Fishnet pattern is seen in pemphigus vulgaris. All are vesiculobullous lesion except the scabies. So dermatitis herpetiformis, pemphigus and pemphigoid are vesiculobullous lesion. All of the following are bullous lesion except none of these or atopic dermatitis. So pemphigus vulgaris, dermatitis herpetiformis and pemphigoid are the bullous lesion. The following diseases are characterized by bullous eruption except lichen planus. So in Porphyria cutanea tarda, variegate porphyria and dermatitis herpetiformis, there will be the bullous eruption. Bullous skin lesion are seen in all except lupus vulgaris. So bullous skin lesion is seen in impetigo, DM and porphyria. Subepidermal splitting is not found in pemphigus foliaceus. It is seen in bullous pemphigoid, dermatitis herpetiformis and burns. Subepidermal lesion are all except pemphigus vulgaris, Haley-Haley disease, Darier's disease and acanthosis nigricans. So subepidermal lesion is bullous pemphigoid. Intraepidermal acantholytic blister is seen in pemphigus vulgaris, paraneoplastic pemphigus and epidermolysis bullosa. Intraepidermal lesion is seen in pemphigus vulgaris, paraneoplastic pemphigus. Then intraepithelial bulla is seen in pemphigus. Bullous skin lesion with intraepidermal split is a feature of pemphigus vulgaris. What is not true about erythema multiforme? No vesicle is not true. What is true is it is associated with herpes simplex, involves distal part of extremities and target lesion. Intraepidermal vesicle are seen in pemphigus vulgaris and carcinomatous pemphigus. Intraepidermal blister are seen in pemphigus foliaceus and bullous impetigo. Intraepidermal blister are seen in all of the following condition except pemphigoid. So it is seen in pemphigus foliaceus, pemphigus vulgaris and paraneoplastic pemphigus. Intraepidermal bulla is seen in pemphigus. Which layer of skin causes vesicular changes in case of burn? Dermis. Blister formation in burn case is in subepidermal. In pemphigus vulgaris, Zank's smear shows the acantholytic cells. Zank's smear is for herpes zoster virus. The Zank's smear multinucleated cell are seen in chickenpox. A patient has bullous lesion on Zank's smear, acantholysis. Then Zank's smear is positive in herpes simplex. Acantholysis is seen in Haley-Haley disease, Darier's disease and pemphigus vulgaris. Acantholysis is seen in staphylococcal scalded skin syndrome, Haley-Haley disease, Darier's disease and pemphigus vulgaris. Acantholysis is seen in epidermis. Acantholysis is due to destruction of intracellular substance. Acantholysis is seen in all of the following except bullous pemphigoid and toxic epidermal necrolysis. So acantholysis is seen in pemphigus and is Stevenson-Johnson syndrome. It is not seen in bullous pemphigoid and toxic epidermal necrolysis. Nikolsky sign is positive in all except bullous pemphigoid. Nikolsky sign is positive in pemphigus, toxic epidermal necrolysis, and staphylococcal scalded skin syndrome. Nikolsky sign not present in pemphigoid and vitiligo. It is present in pemphigus and staphylococcal scalded skin syndrome. Nikolsky sign is positive in pemphigus. Hailey-Hailey disease is benign familial chronic pemphigus.